not just talking about in this country, but worldwide, a man who's done more in the research not only of the dietary implications of multiple sclerosis, but in diagnosing this disease, and really been on an innovative front for multiple sclerosis. I found out about this doctor when I was in medical school. And the way I found out about him was when I was in surgery, there was a necessary component of every blood transfusion, and it was a little instrument that was inserted between the blood and the patient, and it was called the Swank filter. And little did I know that the Swank filter, which everybody praised, they were so excited about it, thought it was the most wonderful thing in the world. It filtered out components that you didn't want to get into the patient. Little did I know that someday I was going to become a good friend of this man, and also a great admirer of him. And little did I know I was going to learn a tremendous amount about diet and disease from Dr. Roy Swank. As a matter of fact, after I finished the last MS program that we gave here, Dr. Swank sent me a copy of a book that he published in 1959, which talked about the deleterious effects of the rich American diet. And as I told him in a conversation a few weeks ago, that I hope he didn't take me to court and sue me for plagiarism. Because plain and simple, the ideas that I have learned, rather independent of Dr. Swank in some ways, and also concerning multiple sclerosis as a consequence of his work, are ideas that he knew about, when I was, 14 years old. So he's a real pioneer and has a tremendous amount of information to share with all of us today, and I'm sure you will remember this morning for a long time. Dr. Swank, can I turn this morning over to you?
The last time I talked here, which must be at least 6 months ago, I spent a good deal of time talking about why did I start the low-fat diet, how did I get into this. I'm not going to repeat that because we have a lot of other things to talk about this time. So I'm going to start right in with the diet and the results of the diet, and then go on to some other things. Let's see the first slide. This essentially this shows us the diet as we devised it about 1949. Here's a normal diet at that time in Canada, which we determined from talking to a large number of patients before they came on diet and to other patients. And here's the low-fat diet. You'll notice here the total lipids are reduced from this value to this value. The unsaturated fats, that is the oils, are increased a bit in our diet. And the saturated fats are reduced about 90%. Proteins run a little lower than normal, and carbohydrates were allowed to be consumed as the patient needed them for energy. There's some differences here between the diet which I use and the one that Dr. McDougall John uses, but this is based upon the fact that our patients tolerate the oils very nicely, no problem with oils at all, and it seems now, after many years, that, and I'll show you the reason for this statement, that these people have a specific idiosyncrasy or intolerance or sensitivity to saturated animal fats. But this sensitivity does not exist for the oils. Next slide, please. These patients were placed on diet beginning actually in December of 1948. And as I saw patients, they were added through the years. One of the first things we noticed was a marked decrease in the exacerbation per year per patient. During the first year, there was about a 70% reduction in exacerbations, and in the next 2 years, about 5% each. And we published our first paper along about this time, at which point there was an enormous decrease in exacerbation rate. We've continued to follow the diet for follow the exacerbation rate for 16 years. Came down to a level which was about a reduction of at least 95%, and stayed down there during the 16 years, and has continued to be that way. So you have a rapid drop in exacerbation rate, and followed then by a very low level of exacerbations going on for years. Next slide. On the diet, at the end of the first 20 years, we did some analyses of what had happened. The only thing I'm going to show you is that of that period is the death rate. These are over on the side here. We have the years of the duration of the disease in years. Down at the bottom, percentage of patients who have expired. And the black is my own series, and this is a Muller's series from Sweden, Allison's series from Ireland, McLean and Berkson from the Mayo Clinic, the VA from this country, from the veterans. Here we have Muller again, and here we have Allison again. Here we have our death rates at the end of 15 years. And you see, if you follow these through, the death rates in our patients are considerably less than they are in any of the other patients. There's about a 70% death rate in Allison's cases at the end of 35 years, and in our cases at the end of 35 years is a little more than 20% death rate at that time. Now this study was reported in 1970, which is about 20 years after of dietary treatment. Next slide, please. Now we're looking at the end of the study. This was 34 years. This is a graph of what happened. Here we have on the left the disability rating. We call it the neurograde. The top here is no disability at all. Number one, the patient has some neurological signs, but he's able to perform normally. Number two is he's beginning to have difficulty walking. 3, he has severe difficulty walking. 4 is wheelchair. 5 is bed. And 6 is death. This top line is for approximately 50 patients out of the 150 patients who consumed less than 20 grams of fat a day. The average was 17 grams of fat and 17 grams of oils in this group. At the end of 34 years on diet, at which time the patients were approaching 65, the death rate was 31% in this group. This is taking all of the patients, those who were quite disabled when they were placed on diet and those who had very little disability, and they're averaged out, and it gives a 31% death rate at the end of that time. Now we're looking here at the next group, about 35 patients who consume between 20 and 30 grams of fat a day, and the average was 25 grams of fat and 14 grams of oil, and at the end of the 34 years, 79% were dead. Notice that there's a sort of a level period here at the top, and then it starts down rapidly. So a patient might be fooled into thinking he was doing pretty well, but nonetheless, this is what eventuated. This line here is more than 30 grams of fat a day, averaging 42 and fat and 10 of oil, 81% death at the end of 34 years. Now, there's several important things about this graph, aside from the fact that there's this remarkable increase in death rates with the increase in fat. But the most remarkable thing is that you only have to increase the fat intake above this first group by something like 8 grams a day on average. And then you get this very rapid downhill course, ending up not much different from those who ate much more fat. And I would suspect that this is similar to the curve you'd get in the average population. So this is what makes me believe that there's a specific idiosyncrasy or intolerance or sensitivity to animal fats, but not to the oils. Now notice here another thing. The less fat one ate, the more oil. Notice here we go 17, 25, and 42, and notice that the oil decreased as the amount of fat increased. And we noticed that all along, that whenever a patient ate a lot of oil, he ate very much less fat, and when he ate a lot of fat, he ate very much less oil. And there's some sort of a reciprocal relationship here. Patients don't tolerate a lot of grease, I guess, in their mouth or in their stomach. Something like that, something simple. Let's have the next slide, please. Now, if we take and divide them into two groups, there's 75 here and about 75 here, and we divide them again into those who had had the disease less than 3 years. That would be this dotted line. And here is the, for the entire group. It's the same as the top line in the previous graph, where there was 31% dead. Those who had had the disease less than 3 years had 21% death instead of 31%. And then you'll notice there was a better outcome all the way along. And the same thing is true down here when you take the other half, where the death rate was 80%. If those who had had the disease less than 3 years, when placed on diet, the death rate was only 65%. So you see that there's an element here of time. The longer you've had the disease, the more difficult it is. However, there are many exceptions to this. There are people who've had the disease 20 years who have done exceedingly well in diet. So, but the point is, I'm showing you averages now. You see some of the other things a little later. Next slide, please. I've divided them here into two groups. Those who had were minimally disabled, in other words, had neurogrades of 0, 1, and 2, that's the dark solid lines, and those who had neurogrades 3, 4, and 5 at the beginning, the dotted lines. And then I took those two and divided them into those who did not deteriorate more than one neurograde, and those who deteriorated more than one neurograde. Obviously, the top group who deteriorated less than one neurograde, there would be no deaths. And then the other group, the 79 and 8/10 were dead at the end of the period. And those who had deteriorated more than one, 79% died. Now the average fat intake was 195. Here it was 34 grams. And if we take these, those are the patients who had severe disability. Those who deteriorated less than one grade consumed 21 grams of fat. And those who consumed more, who deteriorated more, consumed 32 grams and had a 92%. What I'm pointing out here is it possible for patients who have considerable disability to do very well on diet. Not only do the early cases do well, but the more advanced cases have that possibility. Next slide. Now, I mentioned before that the duration of disease before placing on the diet had an influence on the result. And this graph here, which is a little bit complicated, that shows that. Let's take, here we have percentages of the neurograde change and of the number of deaths. And this is less than 1 year, less than 2 years of disease, 2 to 5 years of disease, and more than 5 years of disease. But you notice that the death rate and the deterioration increase as the duration of disease increases prior to placing patients on diet. This is a little bit just difficult to understand because it's complicated by these figures down below, but let's forget about them. All you need to look at is the increasing disability and death rate the longer the delay before starting diet. Here again we're looking at averages. Next slide, please. Now, this has been recently published in Lancet. Unfortunately, they didn't put the pictures in, which I thought were the more impressive part. They just put in the tables. But We divided the patients into those with minimal disability, in other words, neurograde 1, those with moderate disability, neurograde 2, and those with severe disability, neurograde 3, 4, and 5. And here we have the neurograde again, the disability grading. Here we have the years on diet. Take this first group, minimal disability. There were about 25 patients in this group. And 21% of those were dead at the end, of those who followed diet carefully were dead at the end of 30-some years. But 3 of those cases died from cancer or heart disease, not from MS. If you remove the patients, remove the deaths from cancer and heart disease, only 5% of these patients died in the period of 34 years. Those who did not follow diet, here these are 18 grams, here's 27 grams. Those who did not follow diet, 80 and 83% were dead at the end of the, well, in about 24 years. They died during the course of the experiment. This 5% all lived to the end of the experience, and so did the 21%. Now let's go over to the moderate disability. First, just let me back up a minute. I want you to notice here, we're dealing here with early cases, patients who were able to perform normally but who had neurological findings when they were placed on diet. Those who followed the diet carefully did very well. 5% of them were dead at the end of 35 years or 34 years. And if you add on to those who died from cancer and heart disease, the death rate was 21%. Those who did not follow diet had 80 and 83% death rate. Now we go to the moderate disability, grade 2. These are patients who are beginning to have a little bit of difficulty walking. And here we have the same relationship. Starting at 2, at the end of about 30-some years, average of nearly 30 years, 34% were dead, or 40% were dead, and if you remove those who died from cancer and heart disease, then only 34% were dead. Those who did not follow diet, it was 66 and 76% were dead. If we go over here to the severe disabled patients, you'll find similar relationships, starting out here below 3 on average, 33% dead. If you remove the heart and heart diseases, heart deaths, and the cancer deaths, is 21%. And if we take those who failed to follow diet, the death rate were 83 and 85%. This shows again the importance of starting not only early, but starting early as far as the disability is concerned. If you start before a patient has difficulty walking, or before they have difficulty performing physiologically, you might say, you have about a 5% chance of dying over a period of 34 years, provided you follow the diet and follow it very carefully. If you don't follow the diet, you saw that in the slide before. That comes down here to 80%. Next slide. So what we've come to an additional conclusion. Not only does the diet do something, but the earlier you make the diagnosis, the more it does. And how do we make diagnosis now? Well, the only method we have at the moment, which is more or less conclusive, is this clinical diagnosis. The laboratory tests are helpful, but they're not 100%. Now here's a MRI. These are cross sections of the brain, or horizontal sections like this to the brain. See these little white spots? Those are lesions of multiple sclerosis. Here, the small ones over here, the ones over here, here, probably one there, but mainly they're on the top of the head here, the top. Those are pretty indicative of disease, although you can be fooled by cancer, multiple metastases, or abscesses. In our experience, these are positive in about 65 to 70% of MS patients. In other words, they fail to show the disease in a large number of patients. Next slide, please. But when it's positive, it's excellent information. We use the red cell electrophoretic mobility test, and which is really the movement of red cells within an electrical field. And what happens in MS is that the movement is reduced, drops by more than 3%. And here's a graph showing what happens. These are MS cases here, showing percentage of cases which are positive. In all, about 85% of these cases were positive for MS. This is a gray zone through here where there's an overlap of normals and of the MS cases. So you see here again we have a pretty good method, but it's not absolute. There's a mixture, there's an overlapping of the normal cases with the MS cases. About 85% of these are positive for MS, and about 5% of normals can give a positive test. Next slide, please. Last night I showed you where I talked about plasma. I didn't show this slide, but I thought I'd just bring to light what we talked about last night. I pointed out that if you give plasma to a patient with MS who has an abnormal electrophoretic mobility test, which puts these results down here in this area, which is the abnormal area, that the mobility test would become normal in most patients. Up in this area is normal, and then for about 2 months, 60 days, and then we'll float back down into the abnormal area. If you repeat the infusion, it will become normal again. And along with this change in the mobility test, the patients are rather definitely improved temporarily through this period. We use it, have used it for years, the infusion of the plasma in patients after operations and after childbirth, and have been extremely successful in preventing exacerbation of disease. And this was just merely to show you possibly why the patients are benefited. Do we have any more there, Ed?
One more. One more slide.
Let's see what it is. Oh yeah, you're interested in vascular disease, and I just have a slide here from that we did in 1958 on cerebral vascular disease. We measured blood viscosity and that, and here are a group of patients with plasma viscosities at the beginning of the study. They were followed here for 24 to 30, nearly 30 months, and this is what's happened. Out of this group, I think there was one, well, they all came down. None of them went up. Some of them came down rapidly, but generally speaking, they all came down about 10%, which would give you about a 20% increase in circulation through the brain. And the patients seemed to get, we never pursued this because it's a little difficult to pursue both things the way we were doing it, but it's another advantage of a low-fat diet. That's it? That's the last of it? Well, what comes from this, as I see it, is that low-fat diet is very helpful. It can control the disease. If you start it early, patients can we have a 95% chance of preventing disability from developing in patients over a very long period of time, 34 years, provided they follow the diet carefully. If they go off diet for any period of time, like months or so, the chances are pretty good that they will begin to get into trouble. And if they're off diet for a long time, sometimes that trouble may not come on for as long as 5 years, but then when it does come on, it comes on with a vengeance. And the other thing that's important, it's absolutely important that the diagnosis be made early. If you don't make the diagnosis very early, you get relatively mediocre results. In other words, you'll hold the patient pretty nearly where they were, but you won't prevent further disability. I think that's perhaps the results of the study so far. And what we're doing now with the plasma is we hope that we will have something even more helpful because of the fact that we get benefit from the plasma itself, which we are using now in patients to make it possible for patients who have a lot of fatigue to continue working. If this material we have seen or have identified is that material which helps the patients, and we can get it out and and infuse it, then we'll have something very worthwhile. But that's all something for the distant future. Any questions?
Would you repeat what you just said?
Pardon?
Would you repeat about if you don't catch the patient early, then the range of disability is greater?
Yes, if you wait until the patient is disabled before you put him on diet. This is really what it boils down to, and it's usually early. The patient doesn't do so well. In other words, you may prevent him from getting a lot worse, but you won't make him normal. Now that doesn't mean that some patients who have had the disease as long as 20 years, but who have remained sort of only mildly disabled, some of those patients have done exceedingly well. But you don't find very many cases like that. So in a statistical study like this, they don't add up very fast. Yes?
What is it, 34 years ago, what was the average age of the person who was diagnosed with multiple sclerosis?
The average age then was 33 or 34. That means at the end of 35 years, we would be approaching 70 years. Yeah. And in 70 years, there is always a few deaths. Yeah. Yeah. Pardon?
The infusion?
Yes.
Is that a difficult thing? And how many patients do you use that on? Many patients?
Well, we've used it on several thousand. And
is it a difficult process to go through?
No, it's done routinely for a lot of blood diseases, for example. Plasma is used in treatment almost routinely. And it's given following operations for people who have had blood loss. It's used a lot.
So there's not a lot of danger?
The only danger is that if you're in some areas of the world where AIDS is common, there can be some problems. And you can also get hepatitis from it. There's a type of hepatitis, non-A, non-B, which occurs in about every 1,000 or 2,000 samples. And if you get one of those bloods, you'll get hepatitis. But we haven't found the hepatitis very severe. We've had about 20 cases in our experience, and none of them have done poorly, and most of them we didn't know they had it until we did the chemical tests and found that they had liver function tests, which are abnormal. Yes?
Who does the plasma infusion in this area? Or
Pardon?
Who does plasma infusion?
In this area? I have no idea.
You don't have any.
We have a few patients in California getting plasma infusions now and then, but
I had one of your patients call us, and she's moving here in a few months, and she wanted to know who did them in this area.
I don't know.
You don't know. Who do you refer them to?
I tell the patient to go see a doctor of theirs who they get along with, who will listen to them, and usually then the patient or the doctor calls me and I talk to him. I'll write them a letter, send them instructions, and usually it's done that way. It's not done by any one person, but by the patient's regular doctor. You will not be able to get a neurologist to do these infusions. We have almost totally been unable to get it done by neurologists, but most of the time it's done by an internist or a general practitioner. Yes.
I have a question. I read your book, and nowhere in there did I see anything about prednisone in the treatment of MS.
I think that gives you a pretty good idea of how I feel about prednisone.
I wanted to know what your thoughts.
Well, there is something in there. I just said we don't use it because we don't think it helps. The history of prednisone is very easy. It's like this. The first 1 or 2 attacks, you get very good results from it. After that, you don't get any further good results. And that means, and we know that the early attacks usually, not always, but are usually very mild. Mild attacks recover quickly. Later on, they don't recover so quickly. So that's been the way. And we don't give prednisone unless, well, you sometimes get caught in a situation where the patient insists on something and maybe things aren't going well. But even then you don't do well. And there's a lot of problems with prednisone. Often it's given for a long time, patients get very nervous, they start gaining weight, and there have been even some psychotic episodes with prednisone. This information I get from the history of patients prior to when I saw them. But I don't use it.
So neurologists will recommend that only because that's the only thing that the neurologist has at his disposal?
Well, it's sort of habitual with them. They give it. You know. We don't give it. Yes.
Yes. Does the decrease in red blood cell mobility, is it correlated with a decrement in sensory, motor, and cognitive functions?
No. And changes in the mobility don't indicate anything. In other words, unless the mobility starts dropping, and sometimes patients on diet a long time, the mobility will gradually drop to normal. But that doesn't mean that there's no disease. And the patient at that time gets very active. This usually happens in early cases. The patient then gets very active, the tests will become positive again. And generally speaking, the mobility is really the mobility is related to activity. The more active a patient is, the higher the mobility.
One of the things that they asked me, Dr. Swank, was what was involved in an attack, and I told them that I would wait to share one of your theories on blood sludging with them. And so if you could explain to them, what you feel about the blood sludging issue, and I just happen to have your video here.
Oh, yeah.
So I'll roll that whenever you would like.
Yeah, which one do you have?
Well, the one that, the 90-second one I made that I promised to give you a copy of.
Oh, yeah.
Remember that?
Well, early in the early 50s, because we became interested in fat in this disease, we started studying the effect of fat on the circulation. We were using dogs and humans and hamsters at that time. And what we found was that after 3 hours after a large butterfat meal, you'd find the red cells starting to clump up. And in the hamster, where we studied the live circulation, you could watch the circulation slowing down and sometimes stopping for a period. And so we began to think in terms that this abnormality in the plasma, which we had become suspicious of being present, we began to think that there must be something which is missing in MS, or which is abnormal in MS, which prevents this clumping, and that this clumping in MS causes damage to the capillary system of the brain. And this destroys what we know as the blood-brain barrier. You perhaps have read or heard about the blood-brain barrier. The blood-brain barrier is the endothelial cells. The cells lining the blood vessels of the brain are very tightly approximated. And they're so tightly approximated that they prevent certain substances from leaving the bloodstream and going into the brain. This is specifically done to prevent toxic elements from getting to the brain. When the blood-brain barrier is destroyed, then these toxic elements get into the brain and can cause damage. So we began to think in that way. And I'm still thinking in that way, that that's as good an explanation as the mechanism as any, because we know that the blood-brain barrier does break down in MS. That has been demonstrated. It was first demonstrated in the early 40s, and now we have lots of that information along that line. And I think we know that the fat has something to do with the disease. So we have a couple of things which you can pin your pin to, you might say, something which is reliable.
Get this going. Why don't you show them what the film that you actually...
Yeah, I'd like to see it too. It's always a joy to see your own pictures.
Okay, there you are. You can explain that to them.
Okay, fine. This is in a small venule or small capillary blood vessel. This is a venule. Notice the circulation is slowing down. You saw it before when it was normal. Now it's normal again after recovery. Let's see.
Here now you feed the high fat meal.
Here we are. Here we are. See here. See this very slow circulation. That's very abnormal. Marked stickiness of the red cells to one another. Here's clumps right here, and some white cells right there clumped. And now it's beginning to. This is during this period of what you see the clumps down here. The circulation stopped, and here we see again big clumps floating through this vein. This is the cheek pouch of the hamster.
That's it?
Yeah. That's the kind of thing I suspect may be happening. Although that's, we've seen it in a hamster like that. And we know, for example, that in humans, the sludging occurs in MS, in advanced case of MS. I guess that's all I have, unless there's a question. Yes? Yes?
Our individuals, I'm still looking at that tape. Well, on the first part of that tape, if we did a low-fat blood flow through the capillaries, would that be much different after a meal on the scope there?
Excuse me now. What's that now? If what?
If that was high fat, right?
The low first ones were normal diet, no fat, no meal.
And on the scope there, if you took blood flow through the capillary and the low fat, what would happen after a meal? Would it still be slow? See what?
Well, let's see this. Oh, these are after fat meal.
Without fat, how would the blood flow through the capillary?
If you have a
Those-
low-fat diet meal, would that speed up the blood?
Oh yes, yeah.
Be different?
You have a reduction in viscosity on low-fat diet, and you do get an increase in flow.
But were these MS patients?
No, they're hamsters. Hamsters.
That's what I thought.
Volunteer.
These are hamsters. No,
What he's trying to tell you is you also see this in people.
this occurs in people.
That
Yeah.
happens with- I mean, a heart disease patient could improve by going.
See, there's been a lot of work done on this in heart disease, and they show the same thing. This was actually the first demonstration of this, so
This was done by Meyer Friedman here in San Francisco on people. It was done by a fellow named Williams at the University of South Carolina and Peter Quo at the University of Pennsylvania, all subsequent to Dr. Swank's work. And they did it all in humans, and they photographed the conjunctiva of the eye when they did it in people. They were never able to show movies like this because you just can't keep the eye still enough, or you couldn't then. And so what they did is they took still photographs. And what they found in the work by Friedman particularly is that when they fed safflower oil, they caused at least as much sludging as they did with animal fats. They fed them cream the first time, and showed this profound sludging. Then they fed them safflower oil the next time they did the experiment, and they showed the same kind of sludging, which was different, I know, than your work.
Yeah, we didn't find that. We found it we did a series of studies in New Hampshire in which we measured the oxygen availability in the brain. And on high-fat meals, we got an enormous decrease in the oxygen of the brain, about a 30% decrease. And in the safflower oil, we got about a 10% decrease in the oxygen in the brain. With protein, we got also, and carbohydrate, we also got slight decreases in the oxygen. But with the fats, we got about a 30%, which is 3 or 4 times what we were seeing with the other substances.
I want to tell you, this spring, the same photographer who did the work for Dr. Friedman we're meeting this spring with this same team that did these videos here, and we're going to do a blood sludging experiment on the human eye. It's going to be my eye. And because nowadays they have a technology such that they can take the photographs in living color, and so I will send you a copy of that.
Good.
It'll be after
How much
a large cheese pizza.
Why don't you use cream?
No, large cheese pizza. It's a long time since I've had a large cheese pizza.
Well, the only problem, your time frame with the pizza will be different than it would be with cream.
Well, maybe I'll wash it down with some cream.
Pardon? When would I?
Have an ice cream sundae.
Ice cream sundae. I'll have all those things that I've been trying.
Can I take this off?
I got a few more questions for you.
Oh, you have? Go ahead. Oh, go ahead.
One of the things that I think has people concerned is the issue of whether it would be hazardous for them to avoid all oil with multiple sclerosis.
Well, see, you get some oil in vegetables.
Yes.
So it's pretty difficult to not do. Let's take this in a general way. I showed you that patients who eat a fair amount of oil eat less fat. And the patients you take a patient off of Western diet and turn him loose like we've done after instructing him, he has a tendency to vary a little bit. So if you say, well, eat a little more oil, he'll eat less fat. If you don't say that, he'll eat more fat and less oil. And so one of the benefits of the oil is that the patients will eat less fat if they eat a little oil. And there's something about the oil which makes, to the average individual, makes eating more or less pleasant. That's one of the points. The other point is that we have a feeling that the skin is better in MS patients with little oil, and also that they feel a little more energetic. And but as far as the MS is concerned, fundamental part of the MS is concerned, I don't think it makes any difference. It just makes it easier to follow diet.
Your original studies that you did 20, 30 years ago, 40 years ago, where you looked at people in northern Italy and in Norway and various kinds of countries, they were generally on a very, very low-fat diet of any kind. Is that not correct?
Well, the Italians are on a high oil, low animal fat diet. And the coastal Norwegians were on a low-fat diet, eating a lot of fish. They ate a lot of cod liver oil, incidentally. But the central Norwegians, in the farming areas in the cities, and the Swedes and Scandinavians, they all consumed a fair amount of fat, except during wartime. During wartime, in Copenhagen, in the city, the fat intake was reduced considerably. And in Norway during the war, fat intake was reduced by over 50%. Immediately after the war, they went back on a normal fat intake, supplemented by a quart of milk a day per person. So they got additional fat. And in the next 2 years after the end of the war, while this was going on, the reported cases of MS increased enormously in those 2 years. And during the war, when they were on a relatively reduced fat, but not low like as we think of it being low, The reporting of the cases of MS went along at a fairly low level rate, and increased sharply after the war when they were supplemented. And in Holland, for example, not only were they on a low-fat diet, but they were on a starvation diet, because the Germans had intended to starve the Dutch into submission, and the war ended just soon enough to prevent that.
So you actually saw a reduction in the frequency of new cases and recurrences during this time of tremendous stress.
I think so.
And countries such as Japan and China have very low incidences of this disease.
Very low, very low. I was in China for 2 months. We were doing some work there on this viscosity business, and out of 1 million patients available to the Tokyo University Hospital, they had only 4 cases of MS, which is an extremely low incidence. And those 4 cases were very mild. They consisted all of very mild spasticity of the legs. And they'd gotten to that place and remained more or less at that level. And I saw all 4 of them, and you'd have to say they have spastic paralysis of the legs, which in all probability was MS, but you couldn't be sure of it, because he didn't have anything else to go with it. You like to have multiple symptoms involving different areas of the nervous system to make the diagnosis clinically. So the Chinese, the disease was reported as a rarity. There was a report some years ago of 7 cases out of all of China. And that's pretty rare with pretty nearly 1 billion people.
But do they keep that immunity when they move to Portland?
No, they don't. The Japanese increase, the incidence of the disease increases in the Japanese. It first increased when they moved to Hawaii, and then from there to San Francisco it increased again. But it still isn't as high as it is in the Caucasian population. I suspect that's because of the certain, some bit of their own older eating habits were retained. In other words, it probably continued to eat more vegetables. They just added in beefsteak.
So it would be unfair if I was going to summarize to say that from what you know from worldwide studies, MS is 100% preventable.
I don't think it's 100% preventable, but I think it's about better than 95% preventable.
But if
And the
only
reason
7
now-
Chinese got it out of 1 billion Chinese.
Well, let me tell you our own experience. Our own experience has been that now and then a patient will suddenly just very rapidly go downhill and become terribly disabled. This happens probably to be once in maybe 300 or 400 cases. It's not often, but it does happen now and then. So, and
There are people already with MS that
they have a syndrome which we think we consider to be MS, but it may be caused by something else. Don't forget, we could have several causes for this group of symptoms we have. That's one of the things we would like to know.
So my first question would be, in people without MS, if we took just a general population from birth, and we decided that we were going to feed them the Chinese diet, rural Chinese diet, are we talking about a situation based on what you know worldwide where MS would be virtually unknown?
I think it would be that way here, virtually unknown.
Okay. Now, then I'd assume from what you've experienced, is this is an essentially preventable disease.
Oh yes, I don't think there's any question about that.
Okay. Now, once you get MS, this is another thing that I've learned from you, and I'd like to clarify again. If you're in early disease and you get MS and you follow the lowest fat diet possible, which is the diet you and I believe is best, you're talking about essentially stopping this disease. Is this correct?
You control the disease. Now, there's several things that have to be considered here. There's a process called aging, which we all have. And this aging goes on, so that the old-timers thought that we lost about 1% of our neurons a year, each year, beginning somewhere around the age of 60 and or 30, and going on to death around 60 to 70. That means then if you've lost 20% of neurons in a certain area that subserves a certain function, and you're losing an additional 1% from that year, you're going to get some further deterioration in that area. In other words, if you have difficulty walking, you might expect after some years, even though the MS was quiet, absolutely quiet, that you would get some continuing deterioration.
Okay, so let me ask you again. If someone is in early disease, we're talking about less than 3 years and still fairly mild in their presentation, if they decide to start a low-fat diet, as low as we're talking about, and they decide to follow it strictly, are they talking about a situation where they can expect to have no further attacks?
Our figures show that there's a 95% chance that you will have no further trouble.
And
the number, if we'd had 1,000 patients, we might be even a higher percentage, and you have to consider the fact that some of these people died from cancer, heart disease, and one from alcoholism, and there was an operative death, for example, and one for another disease. So, and in this whole group, there were about 12 heart cases, which is a very low percentage of deaths from heart disease, and there was about 4 deaths from cancer.
For the other thing that I think I've learned from you is that if for each increment of saturated animal fat that you increase in your diet, you increase your likelihood of attacks. Is that correct?
Oh, yes. Yes, I think that's true.
So the threshold is the lowest animal fat intake that you can possibly get.
You, as a matter of fact, we thought that there was a relationship between the amount of fat you ate and the frequency of the disease and the speed with which you went downhill and the frequency of exacerbations. But what we find, actually, what our final study indicates, and I'm sure that's easily the best study we made, is that you eat more than that real low amount that helps you. You don't have to eat very much more, and you'll get into trouble.
So strictness is very important.
Strictness is absolutely important.
Now, when you first start taking care of somebody with a low-fat diet, one of the problems I ran into with some of my patients that you helped me out on was that some of the people I took care of seemed to have trouble the first 6 months of disease. Not attacks, but they had periods of waxing and waning. Is that something that people should expect?
Yes. This fluctuation of the disease continues sometimes for several years, and very early cases will have very little of that, and they will get things under control in a matter of a few months. But patients who have more trouble, who are in maybe class 1 or class 2, they'll have more of this fluctuation, and it'll take a little longer, but they almost always have that. And it just varies to a large extent with the severity of the disease when you place them on diet.
You said to me one time that about 1 in 200 people, regardless of how strict they were with the diet, and just a moment ago I think you said about 1 in 3 to 400 has a progressive downhill deterioration. Yeah. Is that pretty accurate?
That's pretty accurate. I'm not sure what the accuracy is. It's probably between 1 in 200 and 1 in 500, something like that. Now, we had a couple of years ago, and we hadn't had any trouble like that since Montreal. We had one in the Montreal group, and who followed diet, did everything the way we wanted them to. And that was a girl. And then we had 2 a couple of years ago that did this. Now, if you took our entire experience where we followed patients, I suppose it might work out at about 1 per 500 in that neighborhood.
So 1 in 500 does not respond well to the diet.
What
Yeah.
were they when they started?
Well, the one that I remember best, it was doing very well, and we thought she was going to do well. It was an early case, and then all of a sudden she started going downhill rapidly. Now, there's some other factors that figure in that we haven't talked about at all, and that's stress. And this patient that I'm speaking of went through a lot of stress. Her husband left her, for example, and she was left without any security at all. And she then rapidly started going downhill rapidly, and we just couldn't stop it. We did everything we could. We gave her plasma and watched her diet very much closer, as if she had given up.
Do you think all your patients follow your diet strictly, or are some of them liars?
Well, as you see here on the Montreal experience, and I think it's pretty. I think patients are much the same the world over. There was 50% of those patients followed diet very well, and then the other 50%, 25%, were just a little over, and the other 25% were a lot over. And I think this is the way it goes.
You talked about the cause of multiple sclerosis being a high animal fat diet. At least that's part of the cause. But when we got around to talking about resolving these problems, you were very cautious not to use the word cure. Instead, you used the word quiet or remission. Now, what I want to know is if you identify the cause of the problem and you remove it, haven't you cured the problem?
Well, you can control the problem as long as you keep them, as long as you treat them or make them follow your orders. As long as they follow the orders and don't eat fat, then they'll control the disease. I guess you could call that a cure if you want to. To me, it's a control of the disease.
Because you're a standard medical doctor, that's why.
That's right, yeah.
That protein you were talking about last night that is found in MS patients and not normal, if that's there, that wouldn't go away presumably with control.
That's the reason I have felt all along, since very early, since we did our first experiments in '52, that there is something inherited in the plasma. And we have an inherited abnormality there, and I have a feeling that that's what we're looking at. But of course we don't know for sure. It's going to take quite a bit of study. We can see this material. We can tell you the molecular weight of it. We can tell you the response that it has to certain things like Sclerosis, which the proteins adhere to, which makes it very unusual. But we don't know really whether that's a real thing or whether it could be, say, a fellow traveler, or whether there's something else in there. There's also other things to be considered, and that's what we're looking at now.
But you do know for sure it is not an abnormality unless the body is stressed by the burden of a rich diet.
That's right. People get along very well. They're on a low-fat diet.
How about alcohol?
Well, they don't tolerate alcohol well at all. Patients have terrible hangovers from it, and only a very little amount of alcohol makes them quite drunk. And so alcohol isn't used much by patients. I don't think it's very good for patients.
How about coffee?
Coffee, some patients can drink coffee, some patients can't. It's just a matter of what their constitution.
If stress is a big issue in MS, why did patients in Norway during Hitler's invasion get so well?
Well, the thing about it, they were on low-fat diets.
So if you're on a low-fat diet, the thing I wonder is a lot of us don't have control of our lives in the sense that stress is all around us and we just cannot get grasp on it. And sometimes when people feel that way, they say, why should I try? Then actually the diet, even in a stressful situation, is still a key factor. Is that right?
Oh yes, and it will prevent serious stress problems. And another thing about it, that people who have been on the diet 5 or 10 years don't seem to have much trouble with stress. It takes a long time to get that immune to stress.
How about pregnancy?
Pregnancy is bad for MS in one way, in that patients have exacerbations following the delivery. The same thing is true after major operations. They get into trouble. And we have found that if you give them 2 units of plasma or 1 unit of whole blood, that they do very well. They don't have any trouble.
Could the exacerbations of pregnancy be due to the fact that the obstetrician recommends 4 glasses of milk a day and lots of meat when you're pregnant? And when you have surgery, you end up going into the hospital where they feed you a high-fat diet?
Well, you see, that's true with patients, but I'm talking about our patients who are treated differently.
What do you tell people? The hardest thing to do once you get this message across to folks is to get them to do it. Do you have any tricks of the trade that you can pass?
I don't know any tricks, but I'll tell you what I do. I don't know if it's a trick or just or whether they believe me. I tell them that if they follow the diet, they have such and such a percentage to do very well. Depends on where they are on these charts. If they deviate from the diet, you can turn it right over and they have an 80% chance of becoming totally disabled. That's one thing I tell them. I tell them that they have to have persistence. They have to have a real desire to get well or be well, or there's no point in going on this. If they're not really devoted to taking care of their health, then they're going to have trouble. And then finally I tell them, be optimistic. Very helpful.
How do you answer patients who bring to you the comment from their doctor that there's no proof that the Swank diet works, and it's too much of a burden to ask a patient to eat that way?
I don't have much trouble that way anymore, but at the beginning we had a lot of trouble. And let's talk about the beginning when we had trouble. I told them that we had published some papers which seemed to show that they were benefited by these, and that I was quite sure that the medical profession in general had not read those papers or paid any attention to them. And I said, let's look at it in another way. If you don't have MS and you go on this diet, you get a certain protection from heart disease and cancer, and probably some other chronic diseases. And so you can't, even if you don't have the disease, you can't lose anything by going on the diet. So I tell that to some I now will make a diagnosis on very early cases that I suspect and which would not be diagnosed by any other neurologist in town. And I'm not concerned, not worried by the fact that I might miss a few of those. And I know of one or two that I have missed in the past 1,000 or 1,500 patients. But I tell them that they will have better health being on the diet even if they don't have MS. And if they have MS, treating it early like this is very crucial. They'll do extremely well.
So my final question is, why is this diet is so healthy, cuts your food bill by 40%, gives you a great bowel movement, and
At least one.
at least one a day. And there's no contradictory evidence as far as it working or not working, and you've published your data and you've taken care of 4,000 people over 40 years. Why isn't it the first message that somebody gets when they go into the MS Society, at least to say, it'll do you no harm, it may do you some good, we know no reason at all you shouldn't follow it? Why aren't they screaming your name at the top of their lungs from every neurologist's office and every MS organization in the country?
I think it's an economic problem. There's two problems. One is cultural. In other words, our culture has become meat, potatoes, and gravy. And they don't like to leave the culture, just like you don't like to leave your religion. That's one problem, but that's not a big problem because in this country people change their culture every day without any great trouble. But I think there's an economic problem. There's really not much money in a diet. If you tell, when we see the patients originally, and then we see them in 3 months, and then we'll see them probably about 6 months, and then every year. And we do talk to them frequently on telephone if they have any trouble at all. And so they don't have any big medical expenses, and therefore it's not a very profitable business to giving patients diets. The dietitian is the only one who makes any money on this, and she doesn't charge as much as the doctor. I think that's a big part of it.
Anything else?
Well, another thing is that nutrition, in a practical nutrition, or nutrition from the point of view of the human patient, has not been taught in medical schools for years now. And so the doctor, he goes out to practice knowing very little about nutrition. He knows about the vitamins, but we're not talking about vitamins anymore. Vitamin situation is not a problem here. What we're talking about is excesses, not deficiencies, but excessive proteins, excessive carbohydrates, excessive fats. And that seems to be something which nobody seems to know anything about except you and me.
Well, there's one other thing that you're too modest to bring up, and that is they didn't invent it.
Well, this is true. That's true. There's no question about that.
Anybody else have any questions for Dr. Swank?
Yes.
I don't have a question, I just wanted to, I say that I'm here with supervisor for 20 months and a half now, but one of the things that really helped me to stay on it was that I had a constant weight loss. Every week I lost almost 3 pounds for about a week. And it just, because of that, with my MS, before I was fat, and they said, well, you got to exercise so you don't get hurt. Well, I didn't have the energy to exercise, but since I've been on the super diet, I have all kinds of energy. I just want to
Yeah, well,
exercise all the time. Am I getting better?
yeah. Well, this is characteristic. Patients do lose weight, and they're very grateful for that reason. And I suspect it does keep a certain number of people on diet. But that's another benefit. We don't say that the only thing you get out of diet is to help your disease. It helps other things too. Yes.
You brought up the point about the damage already done in the nervous system will also cause damages to the organs they supply. So eventually, maybe you might have been, if you didn't get MS, you might have lived with that heart another 10, 15 years.
Yeah.
But even though you might stop your progression of MS, that heart has been damaged.
Well, I think there's a vascular problem in MS. And the reason I think so, the cold hands, the superficial bruises which occur frequently in patients, the low blood pressure, for example. I think there's a reason for that, and other observations we make which skip my mind right now. My memory is failing, but and that's one of the things that I want to look into before I quit this game, because I think there's a vascular problem. But I think it could be a primary problem. If, for example, our idea that there's sledging of the blood is important, that could be the cause of a lot of vascular problem, particularly at the capillary level, small blood vessel, microcirculation level. Yes.
Does the blood-brain barrier extend into the spinal cord as well?
Yes. But not in the peripheral nerves. It's been demonstrated by quite a number of investigators that the brain is sensitive to normal plasma. So there has to be some way of keeping normal plasma from getting to the brain. There's something in the plasma which is toxic to the brain and the spinal cord. And nobody has really found out what that is. And there's been some studies on it, and they've all found that plasma or serum cause damage to the brain or cause physiologic changes during the brain. And one fellow years ago found that it causes degeneration of the spinal cord. They take small slices of spinal cord and they used urine from patients, and they found that it caused very rapid deterioration or breaking up of the spinal cord. So there's something in the blood which the brain doesn't tolerate, or the spinal cord, neither the brain or spinal cord. There's enough studies so that you can be reasonably sure this is true. There's been, right off the top of my head, there's about 6 studies that I can think of, and I'm sure there are more than that.
It's your last chance now.
One more time about exercise. When you try to build your body up and you're so tired, fatigued,
regardless of whether you're on the low fat or not? You just rest, is that your opinion?
I think you have to exercise, but you have to rest, but you have to, excuse me, you have to exercise, but you have to keep it to a level that doesn't cause you to be tired, too tired. I mean, if you're exhausted at the end of your exercise, you've overdone, and it's actually, if you do that every day, you're going to get worse. So that you've got to start out at a low level of exercise, repeat it every day, but avoid getting so fatigued that you're still tired the next day.
And that depends on the level that you're at.
Yeah.
Not too bad at the top, then you can exercise quite a bit.
That's right.
Moving your hand maybe about it.
Yes, that's right. And I have patients doing things like fiddling around with dumbbells because they don't. The rest of the body doesn't get tired. They can do that sitting down. And but I'm quite sure that exercise is very important, but not too much of it.
You said last night going into a wheelchair sometimes make the person at ease or better and easier for them.
Well, I think we're talking about the painful muscles of the legs, and patients in wheelchairs rarely have them. It's patients who are still on their feet a lot, and the more they're on their feet, the more aching pains they have. I suspect you'd have less of that here than we see in Portland, and it's particularly abundant during the winter months. Well, nearly all patients will have it. And the more they're on their legs, the more they're walking, the more they have, more trouble, more pain they have. Well, I think it's not so terribly cold, but it's that damp, penetrating cold that we have a lot of. They still have it during the summer, but not as much, not nearly as much. I have not a complaint that I hear every day, but in the winter, every patient practically will talk about it. Yes? Pardon?
The very neat neurologist that I've been to,
Yes?
one of the questions they've asked me is, were you breastfed?
Well, you what?
Breast-
Breastfed, yes.
What does that have to do with multiple sclerosis?
Well, there's an Englishman who recently died. His name is Sinclair. You may know the name. He was quite a good friend of mine, and I knew what he was doing. He was interested in breastfeeding, and I think there's a place, maybe New Zealand, where the women still breastfeed their children for a long time. And he was looking into that in the last few years about the difference in MS in New Zealand from the difference in England, where breastfeeding is slowly going out of style. That's it. And also, this is part of the package which has to do with the theory that what the low-fat diet does is to make it possible for the essential fatty acids to be utilized more efficiently. They're used to making, what is it they make? No, I forget. No, not myelin. You know, not testosterone. Well, anyhow. Pardon? You'll have to excuse me. I'll put it off. I'll blame it onto a long plane ride. But anyhow, there's an English theory invented by Sinclair that the low-fat diet makes the use of essential fatty acids more effective. And they are essential in production. That's true. His theory points to the myelin. It makes it production of myelin more efficient. That theory is still not dead. It's like all theories, they hardly ever die. But it doesn't seem like that's a total business. What happened when the electrophoretic mobility test was invented, they thought it was the difference between the movement of the MS red cells and the normal cells was due to the surface of the red cell. In other words, something on the red cell and the normal red cell, which was absent in the MS red cells. And that took hold, and a lot of people thought that was it. But we demonstrated then that you could take red cells from MS patients and put them in normal plasma, and then they reacted normally. And you could take normal cells and put them in MS plasma, and then they reacted like MS cells. So this demonstrated that the problem was not the membrane of the red cell, but was the plasma itself that was abnormal. And that sort of sunk that theory. And then we went on with some other things which strengthened the idea that there's something wrong with plasma. That's where that's...
What are you expecting to get out of your current work?
What I expect, or let's say, if you don't mind, I'll change that. What do I hope to get out of it? Because expectations shouldn't get a hold of you in this kind of game I'm in. I hope that we will be able to demonstrate that this substance is the substance which is abnormal in MS, and it has something to do with fat metabolism. There are ways to do this, and the work is underway right now. That's one thing. That's the first place we're going, or the first job. The next one is to be able to isolate enough of it from plasma, and there are ways of doing this. We don't think there's any reason why we can't do that, to test it to see in patients if it does something, if it's helpful. That I think we can do. Now the next thing, which would be very nice if you could do it, and which I think they will look at, I would look at if I were they, that is that you find the gene which is producing this material, and then you put that gene to work making it for you, which has been done for other things. And then it would be available in large amounts if you wanted it.
Then they wouldn't have to follow the diet, right?
No, I don't think that's true. We have found that even giving plasma, you have to be on a low-fat diet or it doesn't help you. And what this boils down to is it must take a lot of this stuff. And if you only give them, say, 2 units, you might have to give 2 units every day if they're not on diet. And that probably is going to be beyond what can be produced. You see, even on diabetes, the insulin is regulated, is needed for the sugar, isn't it? And if you eat a lot of sugar, you certainly would need more insulin. Or would you? You know more about that than I do. You can answer that.
I know one thing, insulin's not the cure for diabetes.
No, that's right.
And I suspect what you're looking for is going to be like insulin. It's
Yeah.
going to make a supplement, but it's still not going to give the people the help they deserve.
That's what I think. I think that we have one problem which it seems possible to solve, but that this will be the last problem, I think, is unlikely.
Do you think a traumatic experience like an operation can set off MS?
Oh yes, operation and childbirth could both do it.
What do you think the mechanism is? I mean, where someone goes from apparently a perfectly normal life with no indication of MS to having MS?
Well, I don't know what it would be, except that maybe this stuff we're talking about is suddenly used up by the trauma. And then well, I don't know. If during cure, if after an operation you need time to recover, then it may be that a certain amount of energy is drawn from your fat deposits in your body, and you don't have this factor X in your blood to take care of it. I'm just shooting in the dark now. I don't know, but that would be one possibility. But I would think that at least 50% of patients who have a major operation will get into trouble. Not necessarily as the original cause, but as a precipitator of more trouble. Yes.
You said that if a patient went on the diet, and then you said something about 5 years down the road it could return with a vengeance. well, I've been on a pretty low-fat diet, but I didn't know I had MS. Now I'm going to be strictly from now on. But I ate real poorly last year. Does that mean 5 years down the road, even though...
No, if you continued on a poor diet. No, I think there, in most people, going off the diet mildly, it can be carried for a while. But I don't think it's very wise. It's like gambling with your health. And I don't think that's wise at all. And we have examples of that. Patients come in and say that they have to admit that they hadn't been on diet faithfully for a month or so. But they're not way off. On the other hand, we've had patients who've gone way off diet very quickly get into trouble. So I think there's some sort of an addition and a subtraction. And if people go out for to dinner or go to friends for dinner, we tell them that don't eat any fat at all the day before or 2 days afterwards, and be very careful about how much you eat. But don't turn down everything. Take small portions.
If you were to have an operation, what would you advise to?
I would try to arrange to get 2 units of plasma or 1 unit of whole blood. And if you had a husband who has the same blood type as you do, well, then that would be a very convenient way to do it. Take 1 unit of whole blood. Go ahead, you're first.
So it seems pretty clear from what's been stated that you were proposing an exact gram limitation regardless of the total number of calories consumed daily.
Correct.
You can't just say percentage.
No. We've always allowed an increase of oil in working people. And that has worked out very well. And also other things, carbohydrates, for example. But we try to keep the protein down because it's very difficult to eat a lot of protein and not get fat. So that we have kept down.
Would you go back over the protein again? You keep the protein down because of the fat?
Yeah, usually any animal protein has fat in it, practically any. There's some protein, we allow a certain amount, the chicken and turkey breast without cooked without the skin on it, because there's so little fat in it. And that's why, and of course fish. Yeah. Yes.
Dr. Swank, you had mentioned that for a person who is aware, eventually you see yourself out of this game, as you put it. Do you have any associates that work with you right now? Any other neurologists who work with you?
No.
So in other words, all your studies and everything that you have done, which are in print right now, which will probably be in the annals of medical history,
Yeah.
ad infinitum, they'll still be there for us.
Oh, sure, they'll be there. And there are people like John here who is interested. And he's going to carry this on, and I'm sure he'll be the one that stimulates a lot of people to get into this game. I don't think there's any question.
Did you hear that? You're going to carry on his work.
Well, no, I just said that I think that John's going to stimulate a lot of people to use, a lot of doctors to use a low-fat diet. Right now, it's disappointing. I know that because I've had the same experience. But I think with time, it'll change. I don't think there's any question about it. Because one thing you must remember, medicine itself is changing. The doctors no longer have total control. And the government is having trouble paying medical bills now, and they're going to want more preventive medicine. There's no question in my mind about that. And the people are going to demand low-fat diet. I have any number of patients come to me and to go on a diet, and they've tried to get their own doctors to put them on diet, and they wouldn't do it. So they leave them. So that it is changing. I don't think any question. Yes?
In a reading of the MS, and everybody has this theory, two of the ones I've found having strong backers is the autoimmune and the slow virus. What's your opinion on those two?
Well, the first place, there's very little evidence that there's ever been an infection in MS cases. what you see pathologically doesn't look like inflammation, and what occurs at the beginning of the disease doesn't look like an infection. There's no fever, no increase in the white count. The spinal fluid doesn't look bad. It has a little few round cells, but that's about all. And when you look at the brain itself, well, it doesn't look like they've had an inflammatory disease there. It looks like, well, it actually looks very much like what comes from small emboli. And so from that point of view, I doubt the virus theory as a cause. Now, a virus may come along after the disease is underway and cause the disease to get worse. That's another thing. And the autoimmune theory has to have an origin. There first has to be a destruction in the nervous system. But we have lots of things which destroy the nervous system and do not produce MS. Let me name a few of them. Amyotrophic lateral sclerosis raises hell of the nervous system and doesn't cause an MS. And we see cerebrovascular disease does the same thing, destroys large elements. And you can see in the pneumograms and in these MRIs, very enlarged ventricles, for example, indicating marked atrophy of the brain, no MS. So what is a beginning? You have to have, it's not consistent with what we know. It's an idea, it gives a lot of people work, and there's an enormous amount of money spent on it. And I think they are learning a lot about autoimmune disease or autoimmune mechanisms, but I do not believe that it has anything to do with MS, except that as a result of the disease, patients do have a tendency to some autoimmune phenomenon.
I'd like to add, one time I asked a doctor about diet and arthritis. He was a big university professor. He told me that real doctors do not study the relationship of food and disease. And I asked him, what do they study? He said they study biochemistry and viruses.
That's right.
It is not a respectable field to be involved in. It's the relationship between what you eat and illness. It is quackery.
You're all wimps.
We are wimps. Real men study viruses, right?
That's right. I don't think that. I think that idea is gradually weakening. I know from my own experience. I've had my my share of problems with administrations and so forth. But in the last year, I've been magnificently well treated. And looked at it as if all of a sudden they're beginning to think maybe there's something in this.
They even gave you a real office, I guess.
Yeah. So that's my feeling, that there is a change taking place, and we can't go on with these terrible problems we have with Medicare and all the rest of the business. We won't have any money for anything else, and so the only way you could stop this is by movements in the direction of preventive medicine. Either that or put the doctors all on a controlled salary, and that won't work very well. That would be inconsistent with our own system. But to do something about preventing, to improve the care of patients so they had less disease would be very much in line with the thinking of the public. And I think the public understands this better than the doctors do.
Yeah, I think it will be, the demand will come from the commodity.
Surely does. It's already coming from there.
We'll let those guys who don't understand starve to death. That's what we're going to do.
Do you still have a private practice?
Yes. I have a private practice, which is quite large as a matter of fact. And the reason for carrying on this has been to raise funds to continue the work. So I raise funds from the private practice and also from patients and also friends of patients and wherever I can get some money.
I think I can speak personally. It took me a year to get into the office. So it takes a while.
I can't help it, as you know, people I think there'd be quite enough room there if we had somebody else. But neurologists do not want to do this kind of work for the reason that they will then be seeing one kind of patient. They don't want to do that. They want to see a variety. And I'm not sure that it's necessary for a neurologist to see them. I think we could do as well with an internist. A good internist would probably be very helpful because patients have many troubles besides their MS or due to the MS, which an internist could handle very nicely. And a neurologist is totally lost with those problems.
I'm curious, if you said our plaques or lesions kind of react like an emboli, that would be like a stroke.
And excuse me now, what?
You said something about it being like a small emboli in the brain. Would you equate that with having a little stroke?
Oh, I see. You said that, I see. I said that the lesions produced in MS look a little bit like the same kind of lesion you get when you experimentally inject emboli into the brain.
Would that be like a little stroke then?
Well, many times you can't tell the difference between MS and a little stroke.
That's
And
what
in later cases, that gets to be a problem, but there are clinical differences which make it possible to tell the difference.
Well, that's why I was wondering, because you don't usually see reflection patterns like you would in a stroke.
No.
But not in an MS.
Now, all of the things you have, all of the findings, for example, are much less severe. For example, all of the symptoms in MS, particularly in the early phase, are what you might call partial. They're never a total blocking out for any length of time. You may get blindness in one eye, which with total blackness for a while, but it'll recover to the point where you have just a little bit of loss of vision. This type of thing. And most strokes would be somewhat different than that.
Yeah, stroke's usually on one side, and it seems like I get my symptoms on both sides sometimes.
Yeah, well, those are the kind of things that I don't think, and at your age, it's a little unlikely that you'd be having a stroke. Well, if that's it, we'll...
Let's think about